IAT on the progress from those topics. So go ahead, Lisa. Do you want to drive?
Yeah. No, the slides are only here in the main deck. So if you could just advance to the next. I was supposed to do an introduction. My name is Lisa Nelson, and I talk too much, but I am the product manager, co-chair with Linda Michelson of the CDA management group, and so indirectly I end up getting involved in a lot of different topics that are going on, and consequently usually have quite a lot to add. But today my job is to report out on the action items that were taken at the last IAT. As Jean spelled out in the beginning, we're really trying to make these sessions actionable, to be addressing the issues that implementers really want to see changed. And so the 6 topics that we covered at the last IAT, Joginder culls out what are the actionable things that need to happen and change and be addressed as a result. And then the CDA management group goes on the hook to commit to making sure that these issues get addressed. So what you're going to see right now is kind of a report card on how we're doing against the issues that were brought up with those 6 topics. And the discussion topic number 6 was the David Riddle one that we were just talking about. So here we go, next slide. I kind of color-coded out in the, we keep track of these in the regular CDA management group minutes in the item where we govern over having C-CDA Implementation-A-Thons. And basically I counted 11 action items that were taken last time, and 2 I'm counting as completed. I'm waffling on one of them. You can see there's only one green row in the picture, but I'm counting 2 with some recent stuff that just came in the last 24 hours. 5 have been started and we're making progress, but we aren't done. 1 was started and we're absolutely at a standstill, and it's been escalated to the larger HL7 community and to FHIR. That's the red row at the bottom that has to do with topic 6. And 3 of them are sort of dependent on the 5 that aren't completed yet, and so they're pending with no action yet. They have to do with generating examples that would be possible from completing other action items. So I'm just going to, if you want to look at that list yourself, there's a live link in the slides for the CMG Confluence page, but I'm going to take you through a little bit of background on each of them. Next slide. The life to death in CDA, there were 2 action items. One was to identify best practice representation of a deceased person in document header. And I have updated this out on the agenda. Today there is a link to an example that has been approved by the CDA Examples Task Force. So if you're interested in this, there's a record target example that shows what was agreed about how to represent a deceased patient. However, I'm waffling on whether to count this as completed or not, because I'm not sure if we ever agreed on changes to the style sheet or any other sort of rendering conventions. And so maybe if John DeMore is still here, John, can you summarize if you think there's still some things that we need to do to get all the way done with this?
Well, yeah, no, I mean, I don't think there's any changes needed to the HL7 style sheet. I think that was the representation of the deceased indicator was fine there. And we found at least 1 or 2 vendor style sheets that were fine. I think that was more of just a call out to the industry to make sure that if you're doing a style sheet that's not the HL7 one, which a lot of people are doing, that it can represent and show when a patient's deceased. It's just not, it doesn't look like a patient who's alive. The reason why that could get dropped or could get missed by a lot of people is just because it is that schema extension. It's the SDTC portion of that that contains a lot of that information, and it might not be there. So we had some examples I don't think there's much that we can do as a group aside from just to raise awareness around that, which I hopefully, talking about this has. The other thing that's not completed here, which is your second point, maybe I'm cutting you off, Lisa, is the rubric rule, which is, there is one thing remaining on me. I want to try and see if I can find, we've anecdotally had examples of where C-CDA documents are getting information about a deceased patient and something else has changed and it's not been the SDDC, deceased indicator, or deceased time.
Yeah, like the last name or something in the title of the document. Those were the things that we wanted to try and flesh out with the rubric rule so that they could be at least escalated, that somebody could see that it's not being done according to best practice.
Yeah, and it's generally not in the title. It's generally the name that's getting changed, and that's not that's really not an EHR issue. It's much more of a workflow issue, which is someone's probably actually changing some information in the record when patients die, and there might be workflow reasons why they do that. But obviously, that causes issues for patient matching if you actually change the name and you try to put in things like XXX deceased or something like that. So I anecdotally have examples of that from different practices. I just need to try and see if I can sample some data to get that and say that here are the 2 things, or here are the 5 things that we're seeing regularly that might be problematic.
Okay, super. And I believe, John, that there is a Confluence page for the rubric rule IG. And you can add right in Confluence, you can add a row that says, here are the things that we would want a rubric rule to check for that should be reported as a warning or an error. I forget if we use that language. But it would be, I think we would be, minutes away from being green on this row with the last little push of completing that.
Yeah, no, I'm really just waiting for an opportunity when I'm looking at the data for other purposes that I can easily do that. So I'm not actually going and pulling data explicitly for this purpose, if that makes sense. Okay. Because we don't, with PHI stuff, we don't go look just for the sake of looking. So.
Okay. All right, great. So I would say, we're almost green on 2. That's I want to count it as nearly completed. And then on the Gold Star example for putting pregnancy information on a problem list, we did a couple of weeks of an investigation and discussing this example, and we have a good example out on examples task force, and we have agreement around representing pregnancy information on the problem list. So that was a big win for us, I think. Okay, next one. Topic number 2, the payer section. We're working on an example, and I probably, we didn't take an actual action item tagged against this one, but you'll see on topic number 3 that there's some overlap. Linda reported out on work done to look at the payer section and how could we do a better job of identifying payers and writing down, recording a person's insurance card information. And we have 2 things that related to this. One is on topic 3, you'll see the advancement we made in making the extension to the CDA schema to include this new alternate identifier, and Linda made an example of how to use that to represent and be clearer about identifying, I think it was like a subscriber ID and some stuff. So it's not exactly specific to what we aimed to accomplish in this topic. So I think there's still a little bit of work that has to be done in this area. But we've run into some capacity issues in that the financial management work group is slammed right now with a bunch of fire IGs that are being pushed through for the CARES Act rules and the CMS side of that. So I think that we might be delayed a little bit here, but we are, continuing to look at how this new extension might be useful, and we might be able to make some progress, but otherwise we're a little bit delayed due to resourcing. think
also
that's a good
think,
summary,
Lisa,
Linda?
yeah, I also think it's important to note that they are working heavily on their coverage resource for R5. And I think that out of the work they do there, it would be easier to retrofit the template from the work, you know, to make it align with what they come up with
Settle
in
on.
FM.
Mm-hmm.
Yeah.
Yeah. Yeah, and that's good. I mean, that might end up being a common thing, that when work groups figure stuff out in fire, that there's then a good reason and a good rationale for aligning and making change in CDA to align with decisions that are solidified in fire. Okay, next topic. Jean, can you go to 3? Yeah, thank you very much. So this is an area where we're sort of half green, half yellow on this. The extension that was proposed that we discussed last time was voted on and accepted by structured documents, and then a group worked last week to implement it in the schema. The schema has been, that SDTC schema has been updated, and it is posted and now available in the new GitHub location that we were talking about earlier. And maybe, Linda, if you could repost that GitHub location in the chat for people who weren't on the very early part of the call,
Sure.
where you can get that updated schema. And then Linda built an example. And Jean, would it be possible for you to open the, well, or I can share I have the XML example that Linda made. If it's okay with you, I'll just share for a second. Okay.
I can jump in here too and talk a little bit about it. One of the things that we talked about when we reviewed our proposal for the payer section with FM was, I think they were uncomfortable with where we were putting some identifiers. For example, they don't believe, at least one of the members didn't believe that group ID belonged at the member level, you know, the patient level. They believed it belonged at the insurance level. But we came up with 2 that I think everybody agrees did belong at the patient level. And because there are 2 identifiers, as you all know, without some external lookup or understanding of the root, you don't know which is which. So I took Benjamin Fleshner's great work that he did around this with a really nice example and just created it for the subscriber ID and the RX identifier. If you're involved with payers a lot, you may know that those are often the same, but in our scenario, I made them different because they can be. So one of the things I think that threw me a little when I first saw this is, in order to use this SDTC identified by, you have to repeat the ID inside that alternate identifier to match it up. And I believe, I never got a response on this, Lisa, but I believe the reason is that we're order sensitive in C-CDA, and so you can't like intermingle them, you know, like put an ID and then put its SDTC identified by. So
Right.
You match up the root and the extension, and then you can add this original text down there to represent exactly what that identifier is. And in my case here, it is the first one's the subscriber ID, and then the second one is the RX identifier. You could repeat this same concept once we figure out where it belongs. I think I know, but I haven't had any like formal approval from FM for all those other numbers, like the RX bin, the RX PCN, the RX group. All those we think belong at the payer level. So you could start using this extension and help people better understand which identifier is which, without having a decoder ring.
Yes, no decoder ring for these hard to understand rootoids, but we still need to agree on the positional. I'm going to go back to having John. Can I just stop sharing, or do you take it back, or do I stop to get back to the slides? Great, thanks. So we still need to complete figuring out exactly where this alternate identifier would be used to represent the insurance card information, but we are making progress on that. And then we took the action item to update the companion guide to add guidance on using the new extension, and we have not yet added an STU comment against the companion guide to address this, but we will, and then it's really just a matter of when the companion guide or C-CDA would ever be updated again to be able to incorporate some additional guidance. So that's it's making progress, but it's not quite all done enough yet to completely check it all off. And now topic 4 was that was the link to the GitHub schema that Linda added in there. Topic number 4, encounter document creation. This is this ongoing topic that Joe Lammy presented about, and unfortunately, I just think it's not ripe enough, or it's not clear enough, and the conversation will continue with this new Sequoia work group that's starting up. And I guess it's good that we're talking about it, and maybe we'll eventually come up with what the right answer is, or at least a workable solution. And if we don't, people have to make choices anyway about how to deal with this. And so sometimes when the guidance can't come top down, the opportunity exists by still talking about it at the IAT that vendors will come forward and say, well, this is what we decided to do. This is what we decided to do. And pretty soon you get enough mass of people saying, kind of voting or caucusing around what they decided to do, that we can have a rule, have a best practice at least, get identified, even though it's not handed down from sort of a guidance-making group top down. So that's where we stand on that one.
Hey, Lisa.
And, yep.
Might the US CDI process help with this, since we know there are going to be several submissions for notes?
So there's a data class called clinical notes, and there are document types, but it doesn't help us understand the question about the life cycle, that that getting to the when is the encounter actually over. We definitely know that there are clinical note types that are encounter summary types, and you'll see in the next topic some work that's being done to clarify some of the questions that Emma Jones brought forward last time. But I think that the nuance of making encounter summaries and this open question of when do we make them and when is the encounter over, so that the document can be made, or what does it mean if the document is made when the encounter isn't over but it's summarizing the encounter. We're stuck in a little bit of a pickle there right now. So I'm not sure that the US CDI is specific enough to lead us to an answer. I think that they look for implementers to bubble up the guidance, and then they determine when stuff is mature enough to adopt it. But until implementers get to that point where it's mature enough for ONC to say, oh, yes, we see the community is behaving that way and they're ready and they want this to be the rule, I don't think that they're going to force fit it top down.
Right.
I honestly don't know. Maybe the authority in Sequoia, they'll say, we've discussed it for 5 years, time's up, we're going to make a decision, and now this is what the community is going to do, so we can all have apples to apples, or some, who knows? Maybe the quality measure people can exert enough definitional force onto things that implementers would need to do things in the same way, because the quality measure would get defined tightly enough that it would require behaviors to be more similar. I don't know. Does that help? That's why I'm kind of just leaving that one yellow, sort of started but not finished.
Yeah, and Lisa, this is Dee Dee. I'll just add that I know that what you're describing here is what that new data usability work group is going to be working on. It's going to continue the work from Care Quality Commonwealth Communities, and it's going to broaden it. So we're going to focus in the data usability work group on 3 different high-level use cases, and specifically sticking to pain points for those: provider-to-provider exchange, which we've all been working on for quite some time; provider-to-public health exchange, and that's bidirectional public health back to provider as well; and then provider-to-consumer. So we're going to start really bubbling up some of these, what I would call pain points, and hopefully making that more strict in the way of, here's the rules of the road, and hopefully that would then allow folks like Commonwealth, Care Quality, other networks or other organizations, whether it's Da Vinci or whoever, to eventually start taking those items into consideration and adopting them through their governance processes. So you've got the carrot and the stick, both.
Mm-hmm. Awesome. That's great to know. Provider to consumer. That's awesome. And HL7 has a new work group called, they're not so new anymore, Patient Empowerment, and it's a place where the voice of the consumer is definitely coming through. And it'll be, I'll make sure that those guys hear about this new Sequoia data usability work group so some folks could help with that use case. Terrific. Okay, topic number 5 then, please, John. There were quite a few questions about US CDI version 1 data class called clinical notes. And specifically, Emma introduced us to the list. I didn't put it in the slide here, but if you go out to the link that's already been shared on US CDI version 1, you'll see that there is a list of different clinical note types, and it just wasn't making sense given what we know about the different types of clinical notes from our CDA templates and from our FHIR profiles in US Core. It just wasn't all adding up. And so the LOINC document ontology work group came together and discussed some of the open issues that were pointed out at the last IAT, and they got involved to help clarify what they felt as the SDO that's responsible for the document ontology, and that's also where the clinical note codes are all managed and organized. And they have provided some very specific comments back to the ONC about the existing clinical notes data class, and then they've done 2 submissions requesting other data classes to be added. And so some good progress has started on that. I have one more slide to summarize what they've recommended, but once we see how the dust settles on that, then there's some requests to have additional examples created in examples task force. And I think that we'll be able to make progress, especially if, according to Al, they're going to be weighing in on these revisions in a short amount of time, a couple of weeks away. I think we're in good shape to be able to address this. Could I have the next slide, please? The proposal, here's that list I was talking about, but the proposals that they sent in, this summarizes it. The red area in the middle were things that Registry weighed in to say these are not clinical notes and they don't belong in this data class, clarifying that image narrative and laboratory report narrative and pathology report narrative, all of the LOINC document ontology codes that are used to classify this kind of information are used within diagnostic reports and lab reports and things that they do not categorize as clinical notes. And so they're making a recommendation that these be taken out of this clinical notes and added elsewhere. I think there's already a data class that's appropriate for lab and pathology. And then they, I can't remember what they've recommended about diagnostic imaging report. I think maybe they have suggested that would go in a different data class. I can't remember that. I don't know why I didn't write that down. The blue ones are areas that did make sense for the work that has already been done, and they have made some recommendations around clarifying that the concept of, like for example, that 11488-4 for consultation note, that's actually a most general or generic LOIC concept for consultation note, and that there are actually many other consultation notes that are appropriate or could be used in this space, and they just vary by the different 5 axes that are a part of the document ontology. And so they've proposed that some additional language be added to clarify that there's really value sets associated with these different clinical note types, and they have location. The source is with LOIC, and it's also included in the VSAC with the download package that goes with Consolidated CDA, and they've just proposed to kind of tighten all that up language-wise. And then they have suggested to add some additional note types or data elements within this clinical notes data class. And they call out an argument for having a telehealth note, which is documentation of a clinical encounter that takes place via telehealth. An outpatient note, that's the one I think that Rochelle was looking for and might be a proponent for having brought back. Transfer summary note, a plan of care note, and a referral note. And by adding these, the benefit also is that it starts to make a lot more sense given the note types that are also defined in Consolidated CDA. So I think that's good progress, and I hope, Emma, this was your topic from last time. Do you feel like these changes are taking us in a good direction?
Yeah, I do. I actually had a conversation yesterday with one of our inpatient system dev manager about this. And she was asking if they had, like, take consult note as an example. If they had something more specific, because, you know, everybody look at these things, and because this is what it was on USCDI, they really feel like they have to implement exactly towards it. So she was asking if she had something more specific, like a cardiology consult note. Can she use this LOIC code, this broader LOIC code, in the code element and put the more specific code in the translation? You know, so those were they're the kind of questions, because they almost feel as if they have to use this code. You know what I'm saying? The code that's on the CDI list, because that's what ONC has specified.
You know, that's a good thing to take to Examples Task Force. Right now, the guidance that LOIC turned in suggests that what's appropriate is to use the most specific code possible. And so I think that their guidance would be that in the clinical document.code element, you would just use that more specific consultation note type. The place where all of this comes together is in another IG that Russ Ott is working on. I think it's going through what's called the work group called Payers and Providers, something like that, Payer Provider Information Exchange, the PI work group. And in there's guidance that talks about how when you're requesting documentation that you can use this most general consult note, for example, code, when you're requesting, and that the responding system can respond with any type of consultation note that may be more specific, but is still in that value set of all document types that are consultation notes.
Yeah, but this is in Lisa, what the example you're giving is in context of a referral request and a referral response workflow. I think the person I was talking to yesterday, she was inpatient. There was our inpatient system. And she was saying that usually because they generate the discharge summary, and sometimes in the discharge summary, they want to include, you know, textual, you know, like the patient was in the hospital and they got a rehab consult and they got a cardiology consult while they were inpatient, and they want to include those notes as part of the discharge summary. So in this notes section, if they have a console, like a rehab console note, can they create, at the section level, put in the high, code wise, because you can have many note activities within that one section. So if they can put the consultation note at a high level, and in the translation, put the rehab consult, put another consultation note in another note activity, and put in the nutrition consult.
I
Those
don't
things.
believe,
And
yeah, in the,
And same
oh,
with nursing
that
notes.
Brett,
would
you have
work.
a
That would work
answer?
if
Yeah.
as long as validation wise, we weren't saying you should put 11488-4, right? If validation is looking for that specific code,
Yes.
then it wouldn't work. I mean, it obviously semantically is saying, yeah, this is a console note. This is just a specific type of this console note. But you're right.
And that's why they want to put the 11488-4 at the code level, in case the validator is looking for it at the code level.
Section dot, you mean section dot code and section
No,
dot code?
activity.
Oh,
no,
at the activity,
Yeah.
Note activity code.
Yeah.
Yeah, I think that template is built to allow that, Emma. I think that, hang on, let me just see
Because
if I
I
can.
think at the section level, we have to put a generic code.
Yeah,
And then we put specifics in translation.
okay, so I'm back to sharing here. And this is the companion guide, Appendix A, and this is where these additional templates for note activity and the ones that Emma was just asking about are in there. So I'm going to go note activity. Well, let's look at the conformance constraint.
So note section, it
So
has
here's the
generic
code.
type.
Here's
Yeah.
the code, right?
And that's note
you
activity.
shall put this that says note activity. So that is a fixed code that means note activity. But then you can have 0 or 0 to star translations.
Yes.
So it might be 3. You might have this one says it's note activity, and you're required to populate that with this code. But then you could have 2 translations, one that's this general consult note, and then a second one that is the more specific cardiology consult note, if you felt that you needed to have those 3 levels of specificity. But this one is required in the main code at code.
And then when you look at the notes section itself, this is the activity.
The notes section is, I think it's called notes section.
On that, the code elements seems to be generic. It just says note types. So you can almost as if you can put it in long note of note.
I think there is a specific value set, but it's very broad. Like this is a intentionally defined value set that ends up giving you almost every LOINC document code.
Yeah.
Yeah, I think it says classes doc right up there.
Yeah.
But you can only have
Very
one note
broad.
section in your document.
Nope, you can have multiple notes sections in your document.
As long as they all have
Let's
different line
see.
codes.
Yeah.
Yeah, as long as they have all different LOINC codes.
That's the key. That's the key end part of that sentence.
And let's go see where it says that.
There you go. Multiple note section may be included in a document.
Provided they each include different types of note content as indicated by different section.code.
And what if you have 2 of the same? You just different entries in the same?
Will be a few.
So there's note activity is at the entry level, and you can have multiple note activities within each notes section.
Mhm.
So if you wanted to separate, I don't know, cardiology consult notes from diabetes consult notes, and that was somehow, something that you wanted to do, then you could make two different note sections, and each of those note sections could have one or more note activities, but they should be coded appropriately so that you've got note activities that are about your diabetes consult in that diabetes consult note section, and note activities about your cardiology consult.
This may mess up import if you have, because remember, it's only one template ID. They all use the same template ID. If you have multiple sections with the same template ID, because you need, if I have to import, I would be looking for that template ID, right? But I will find more than one.
You should be looking for the section.code. Reliance on template IDs for import is a dangerous habit, and it's the code element is what tells you what kind of section it is.
But then I need to, if I don't know what the section code is ahead of time, what do I know? How do I know what to expect? That might cause an input issue.
You've got a couple other issues. Do you want to take this one offline?
Sure. Well, maybe what would be the action item here, Emma? Do you want to take the action item to work out this example?
Why did I end up with an action?
Well, no, and it won't be. No, it won't be you. But we, would put an action item down that we'd end up having to do an examples task force to address the scenario that you're talking about.
Yeah, I think I had an action item already to work on an example.
Okay. All right. So let's do the last topic so we can get moving with the agenda.
I'll just say, this is Matt. I'll just say one thing, and probably maybe not needs to be said, but the applicable light codes that we put in the US-CDI, the validator will be looking that your system is capable of coding that specific code. Obviously, you could do you can have more than those codes. Capability of capturing more than those 8 codes, or wait, it's not 8, but it's 6 codes for the clinical notes. But just wanted to point that out.
So we should expect to be able to do at least a progress note or something in that note section using that particular code, is what you're saying?
Yeah, you would have to use that progress note code because it's in the US-CDI.
Right. So Emma's idea of setting that and the more specific code in a translation would work. The validator would find that progress note code.
Yeah, and it's just to say, like, as what you said, what Lisa said, you guys have provided feedback, or Reconstrief has, that this is the time for us to maybe be able to fix anything in US-CDI version 2.
Right, because it should align with what people really, need, not this particular code.
These were the codes that at the time of it being published, we were under the understanding that these were the codes for these specific types of nodes.
And the codes are good codes. The point is that there are more codes that are also appropriate when you're talking about that as a data element. So I think that'll be adjusted.
Yeah, many systems have quite a document management system using light codes. It's pretty interesting light committee, actually, because there's so many people, implementers, clinicians that come and say, hey, I need this code for my documents that I'm doing. It's kind of interesting.
Well, I'm glad to know, because I get a lot of questions about, do we have to use these codes? And my answer would be, Matt says yes.
I'm
last
just saying,
slide.
the system must be capable.
That's what they mean when they say, do we have to use?
Yeah,
Does that mean though for testing that they'll have to be able to do those 3 that you have there that are more logically?
that's what the validator will test.
It will test for the imaging, narrative, lab report, and pathology report?
Yeah, well, there isn't an actual code for lab and path right now, so.
It would test for the ones under applicable standards.
Yeah, so right now there isn't any list there, so it would just, and so you would just, it would just test that something was there, that you're able to capture that narrative.
Even though most systems don't put them out as notes per se.
Yes,
Okay,
I mean.
I think we should, this is not marked as green, so it's not marked as done, it's marked as in action. I think that we will owe it to look at this in the context of whatever new guidance comes out for adjustments to USCDI version 1 and for what comes out for level 2 and USCDI version 2, and keep making examples. Okay. Last topic is the David riddle of how to map C-CDA participants to fire resources and fire provenance. And what we found when escalating this, we brought it after being discussed here, it got brought back to patient care. And David Riddle's examination really looked at a slightly different problem. He was questioning how do you populate the participant elements that are built inside the fire resources, not the ones that are externalized in the reference to the provenance resource, but actually the made-to-order resource participations in like condition and allergy intolerance and procedure, and really found that there's not a good fit between the defined roles that we know in CDA and these specific roles that have been added into individual fire resources. And we couldn't think our way through the problem with the definitions that were available. It didn't work. Notions like recorder and asserter and things that have been invented in fire resources are not lining up in obvious ways. And so this remains an open topic, and it's something that's been escalated for work across the fire management group and Fire I and CDA management group to see what is going to be done going forward. I would just say for implementers who are doing this kind of stuff, if you're making decisions and you're having to work your way through it, keep track of what you're deciding and bring it back here to discuss what you've determined you're going to do, and maybe as a minimum we can gel on being able to say at least here's the range of choices that implementers are making today in the absence of better guidance. That's where that stands. Okay, I think, is there a closing slide? I think I just wanted to announce that there is a roadmap that we are trying to create for C-CDA inside structured documents, and we're working on thinking about CDA generally, the roadmap for the standard going forward 3 to 5 years out. And there's a job description that's been posted on the HL7 website for a program manager to specifically look at some of these U.S. realm projects that are near and dear to our hearts in the C-CDA space. So as we mature this product and we get onto regular maintenance cycles and annual cycles to do things like errata releases and value set updates and maybe even eventually some minor and major updates, including moving to a new web publication of the IG that will be using fire tooling, some exciting things like that, ongoing work with companion guides and rubric rules, etc. There's actually enough work to be managed here that HL7 is looking for a nearly full-time program manager resource. And if you're interested in a position like that, go look at HL7 jobs page and apply. I think it's open for a few more days that they're accepting resumes. Next slide. And with that, John, I'll turn it back to you.
All right, thanks.
That was perfect timing.
Yeah, well, she was supposed to be done.
Questions, John. Can we ask questions to Lisa?
Yeah, go ahead.
Hi, Lisa. I have a question regarding the clinical note activities under sections. I kind of put a screenshot, not a screenshot, but image to the chat. While I was researching for the clinical note activity per section, I kind of came across with a, like sections and then what clinical note activity can go with that section. And even the companion guide you had has, like procedure note needs to go under procedure. So we would like to make sure is there any list that, the note activity, like specific note activity can go under specific section type, or there's not such a rule and every sec type, as long as they are meaningful, can go under any section. If, we couldn't find a certain answer, and then again, like from samples and, from researching, we were able to come up with that list, but we would like to check with you all just to make sure, what we have is the right direction, or there is not such list because there is not such a rule. So thank you.
Yeah, I think right now there is, you know how there's a sort of some, I'll say, guidance that can't be machine identified, like the title should make sense given the clinical document.code that's used. The section title should make sense given the section.code that's used. There are times when the guidance says do something that is appropriate and not wrong, and it's not tighter than that. And I think that that's the space that we're in here. There's guidance, for example, like there's a statement in the definition of the note activity template that says the note activity template should not be used in place of a more specific C-CDA entry. Note information included needs to be relevant and pertinent to the information being communicated in the document. There are these statements that give general guidance but not specific in terms of this value set of note would be appropriate when the note activity is inside of a notes section coded with the following code. It's just we don't have, it's not at that level yet, Aslam. So I would say, don't do things that you can clearly see would not make sense, but there isn't anything tighter than that defined right now.
And then can every CDA sec type, other than maybe text only, like maybe instructions, can have note activity, or it is also limited?
This is Emma, we've placed it in sections that can have entries as well as sections that are text only based on use case and clinical need. So for example, we've placed it in procedure section. The procedure section can have entries. If people, because typically in the procedure observation, for example, is list of surgical procedure or procedure that has changed the patient body. So if somebody wants to go into more detail and explain, in a textual way, things that happen when that procedure occurred, they can use the note activity there. And I do understand there is a procedure note document, but this is more for the system that doesn't create all of that information in a structured way. We've also placed it in result organizer in case somebody wanted to give more details specifically about the test, and in result observation. And we've actually gotten more requests. There's been a request to place it in social history, to put it in
maybe family history. Yep. Yep, I could see there, and you know, this is a little bit of a trend. It used to be that the health concerns, everyone was like, oh my God, look at all the different entry types. People weren't used to sections having different entry types that could be present. But now, between the guidance coming from the use of section time range as an alternate kind of entry that could show up in any section, and also now these note activity entries could be in a section, that more and more systems will have to be assuming or looking for different kinds of entries present in sections.
Yeah, because we had a request. I mean, we also put it in reason for referral because people wanted to include a referral letter for ambulatory systems.
All right.
Does that answer your question, Aslam?
Yes, thank you.
Okay. Thank you. Thanks, John.
I point out that I didn't add these maps, and I've been Skyping with Dave because I'm so dismayed that so many states have candy corn as the most popular Halloween candy. I think that
Wrong.
points to what is wrong with the United States. That candy corn would be wrong.
Yeah, and Tennessee has lollipops. It's like, really? Sorry.
What person over the age of 14 actually eats a Sour Patch? Nobody.
Me.
I know.
No, I disagree. I disagree adamantly on the Sour Patch.
But what person?
Sour Patches are good.
But what
And where did
person
they
over
get
the age
this
of 14 is-
information?
So here's the
Yeah.
one. Here's a map I found from 2015. This was an influencer survey. So candy corn was in there. Reese's Sour Patch. I don't know where that one.
Candy corns in Tennessee? Yeah, really? Wow.
You guys.
What's the good candy like Dolls?
I love candy corn.
Okay, get out. Just
Dolls chocolate.
I'm glad that
Whoppers.
glad that Oregon updated.
Jay, have you tried
candy
the?
corn.
Oh,
Have you
look,
tried
hey, the candy corn.
Have you tried the caramel? Have you tried the caramel candy corn, Gay?
Oh, it's so much better. It's so much better, Dee Dee.
I know.
Everybody's Googling it now.
You can only get it this time of year. So if you're looking for it, go look for it now because you can only get it between now and leading up to just a little bit before Thanksgiving, and then it's gone until the next year.
And it's made by Brock, I believe.
Yeah.
Here's 2017. Let's see if I can bring this one over. Make it bigger.
I wonder how big the survey sampling was to get this information.
Well, that 2015 showed 42,000 votes. So this is most unusually popular. So.
Yeah, I'd agree that Almond Joy being
Hey,
popular as usual.
Tennessee on this one has the caramel candy corn. That's the caramel color because it's got a brown bottom instead of.
Swedish fish in whatever small tiny state that is.
Yeah.
I noticed Arizona in 2015 had Toblerone as their thing, and now they have Double Bubble. Come on.
Right?
Yeah.
Downgrade.
I was looking at that.
Who's moving in? Who's moving into Arizona?
Remember, most unusually popular. Right? So.
Oh, okay.
What is Oregon? What is that?
I don't know, and it's here. It's Nestle.
100 grand.
100 grand.
100 grand.
Yeah, that's in Michigan as well.
If you can't sing the theme song or the commercial song to your candy bar, you're not a legit fan. So I'm gonna need you to adjust there.
In North Carolina, I went to York. I hate that candy. York peppermint patties.
I love those.
I do not like that. I don't like anything minty mixed with chocolate.
Yeah,
But I'm limited in the kind of candy I can eat anyhow, right? So.
All right, let's go. If you guys don't mind, we'll go right back. We'll go right into our session. So this is just a recap. Next steps, closing thoughts. I've got a few things to talk about. So we're planning now to have these virtual IAT, well, the IATs and virtual until we figure out what's going on an annual cycle in October, March, July, or March, July, October, depending on. So these would be the dates for our next planned IATs. Obviously, to be, as we get closer, if something comes up, but these are the dates. So please, start saving your dates. March 24th would be the next one. Then July 21st, then October 20th. We would please keep discussions. We've been getting more and more discussions on C-CDA and CDA in general. People have been asking, and like implementers and that, I've been redirecting them to the CDA stream. So we're starting to see more and more people ask, especially in the fire to CDA mapping things. There is a call out for the C-CDA examples task force. We always need to continue that work. And then I have a few, let me bring over my.
Hey, John, on that examples task force, there's a lot of people that have reached out to me about it. I don't think people know it actually is on the calendar for HL7. It's on Thursday. It follows structured docs call, and it's noon Eastern, and adjust your times accordingly.
Yeah, it is a scheduled call that's in the conference call center. I have it in my calendar. So yeah, I just don't know it, but yes. So these are some of the questions that I believe, well, I know that they're coming from the CDA management group. So these are things for people to start thinking about. We don't necessarily need to have long conversations, but mappings between consolidated CDA and fire. Obviously, we're getting questions about those. There's a couple implementation guides that have some preliminary mappings. So the question we have out to you guys, to your organizations, is how important is it to your organization to have standardized mappings? And is that something that we should maybe put in the US core? I'm sure if Brett's still on the call, he's shuddering at that suggestion, but somewhere within the US core or within a guide that the US core references, something like that, to have those kinds of standardized mappings. The updating of consolidated CDA, given for those of you who are at the working group meeting and the stated board policies of fire being, where we want to focus on, obviously we're not abandoning consolidated CDA, but what we're trying to do is come up with what's the update cycle for that. And so if we were going to update consolidated CDA, what changes would be the most important for your organization to have included? And conversely, if we were going to remove some document types, if we were going to say these document types, they just don't have the uptake we thought, which ones of those could we be removed without any negative impact? And it might end up that none, we have to keep them all, but it's something that would like to see the implementers provide some feedback on. And we're moving towards publishing CDA in the same sort of fire way, and same thing with consolidated CDA as in that same sort of fire implementation guide or the new implementation guide format. And that leads us to the way I mentioned this at the beginning of today. If we broke C-CDA down into individual templates and managed them as individual templates, so you'd have a GitHub repo, lots of little parts, and then we released once a year. Would that be something you guys would be able to absorb? Would it be easier to absorb than, one gigantic update in a document? And then how often would that update cycle, would you want to have that? Would an annual update for implementers or a quarterly or monthly errata release? How would updating the individual templates, how would that work for your organizations? So these are some big picture questions that we would like your organizations to think about. We'll probably schedule for the next IAT, but if you have any suggestions, please send them to Lisa or Linda as CDA management group chairs. You can send them to Jagina or myself, and we'll forward on to them as well if you have any answers to these.
Can we ask a question now?
Yes.
So I know that there's work, and I know I've asked a couple people this stuff, to get C-CDA fully on the web. I know that there's the work to put it in kind of the fire mechanism for publishing for it, but is there a timeline for when C-CDA would be available outside of a PDF and on the web?
No, yes, but no. I mean, we're working on it. Lisa, I don't know if you want to step in. So we expected for the September working group meeting for it to be further along than it is. So there is a timeline that we're trying to get to have that available. It's just, it keeps slipping, I think is the best way I could put it. Lisa, do you have any other?
I think that the last reports that we had estimate that it would be possible for this pilot round of, just sort of doing the main bulk conversion, kind of a machine conversion from existing template syntax to the fire structure definition by the end of February. But that estimate was given assuming that the project was advancing starting at the beginning of October. And, we're already at October 21st, and so we've, slipped another 20 days. I think that we probably are up against unknowns and resource slippages. So thinking that we'd have, Brett and I talked the other day about, what if it was possible to put enough resources on this that we could do an informative ballot in either May or September 2021 so that the implementer community could start to take a serious look at what we're calling basically C-CDA 2.2. It's just a pure port from the old way of representing it in the PDF to this new way, and we're what ifing that was possible right now, that it's that close. I don't think it's going to be much longer than that.
Two things there. You can't really call it 2.2 because that assumes it's built on 2.1, right? So we'll have to come up with a new naming convention, I think. And then the second thing, when you say it slipped, I think that it isn't because the resources hired aren't doing the work, that we're waiting for HL7 to recontract, right?
Right.
Okay. Does that answer your question, John? I think it does.
No, thank you. That's the best I guess we have on it. I'm left noodling. I mean, I love the fact that we have more in GitHub repos than we did a year ago. Like this, there's just such benefit to having information available on the web. It's, having it just locked up in the PDF that people have to download it limits exposure, and it makes it harder in some respects. So I think that this is great work, really important stuff. I know it's just hard to figure out how to get done. So.
Yeah, it is. And bubbling up, John, thank you for that comment. I think that if there was more obvious support and cry from the implementer community that this would be great, and it would be great if it could happen sooner rather than later, and with the more sort of assertive commitment to when it would be done by. HL7 listens to what the CDA community has to say, and I think that those comments would make a difference. One of the things that I just asked Dave Hamill in the background is if you wouldn't mind doing a second survey. You have the one that basically is your feedback about today's experience, but if we send these questions out in the survey form and you take the time to answer them and put comments like that in, maybe it would help to elevate both for the ONC and for HL7 that the implementer community wants to see this get moving. The biggest reason that we're doing it is to enable more rapid improvement and change. We've got a list of STU comments that's longer than all of our arms connected together, and we aren't able to make updates, to make version improvements. The most that we've been able to do in like the past 4 or 5 years since 2.1 was born in August of 2015 or something like that has been to create errata updates, very minor technical changes. And for us to get at some of the things that the implementer community has been queuing up that are functionality improvements, we have to get onto a different tool so that we can version and stitch these templates back, all the way back up to a document template, stitch them all back together again in a more usable way. So, think about over the coming years, if US CDI is starting to be on an annual cycle and the implementer community is moving and adopting new things, we can't have C-CDA be frozen And we can't have the situation where you have 7 different companion guides and supplemental guides that you have to be intimately familiar with, already knowing what templates are where, because you can't find anything if you don't. It's not maintainable in the state that it's in right now.
Hey, Lisa, it dawns on me that we have several participants that may not even know what we're talking about here in moving the C-CDA to the structure definition in FHIR. Is there a location where people can see work to date?
The CDA management Confluence page has got our notes and minutes about it, and there is a draft PSS. Natasha, can you stick the pointer to the draft PSS maybe in the chat, and then people can go and read there. It describes the project as a whole. Again, it's just a draft version, but I think it's the best place where we have kind of a comprehensive description of what it means to be able to move CDA IG publishing onto FHIR tooling.
And the work, lest you think when Lisa talks about the one for next year, that's just one of many that will have to be moved. So that's why the PSS is so important. It addresses everything we'd have to do to completely move all of the implementation guides that fall under CDA.
Yeah,
and
and
all
there
the
are tons
other
of
work.
them.
Yeah,
there
that
are
goes
tons
with it.
of them. Yep.
All right, and then the only other thing, we've got notes in the Confluence page, the Implementation-A-Thon notes. You can do a search for Implementation-A-Thon and then get to the 1021. Jaginder's been taking notes in the background. He's still going to he's going to go over the recordings to make sure that we've missed anything. We have a number of action items, and those are the action items that Lisa's going to mine for to bring forward to CDA management group, so we know what's happening and watching them. So please take a look and make sure that we've recorded those action items appropriately. I just did, while you guys were talking, I looked through and they look okay to me, but there's always something that we could have missed. So we've got for every one of the sections, we've got some notes and action items. So please take a look at that.
All the action items are actually at the bottom.
Yeah, they get summarized at the bottom?
Yes.
I should have just gone straight there. There we are. Okay. And anything else from the group?
John, one of the questions I think that we try to do is, we've made some major changes in the way we've done the IAT. Last time was the first time that we focused on implementer-led issues and an agenda that's driven by the CDA community. This is our second time of doing that, and demonstrating some follow-up and getting some wind in our sails of responding to what the community is asking to have addressed. I'd be really interested to hear in the minutes that we have where folks are you happy with these adjustments? What vision do you have for taking these IATs now that we know that you have like 3 more of them coming up in a year? What ideas do implementers have about how to use this time most effectively?
Yeah, and in the survey that Dave sent out, there's I've filled it out already because I had a couple things. There's some good sections, some open-ended sections. So if you have any of those, thoughts about the IAT, about what you'd like to see or how you're going to use these, please fill it in that survey, because that's the area that helps us. I know from the previous one, some of the survey answers were very helpful in knowing what we needed to look for in terms of topics for this IAT, but also things about presentations. So if someone had just a presentation with no action items, we realized the IAT probably isn't the place for them, and we needed to come up with some other way for them to do those kinds of things. So that's something we're looking into at the management group. So yeah, please use that survey to fill in any of those thoughts that you have.
Hey, this may be obvious, but have we predetermined that the ITs are all virtual next year?
Yes.
Yeah.
Thank you.
Until further notice, yes.
And one thing I'll add is recordings from today. You know, I recorded to the cloud, the Zoom cloud, so it's got to process that. And then the process is for me to get it to the HL7 YouTube channel and then get that URL, and I'll upload that URL to the Confluence page. So hopefully I'll be able to do that smoothly, and it'll all be up by tomorrow. I'll email everyone once it's up there, but it might be Friday. I'm not sure if I hit some snags.
So I just want to say, because I've been coming for a while, that this has been really great for our team as well as collaboration. I know we were concerned about making the shift from what we were doing before, and then we had a little time period where we didn't feel like it was super effective. From our perspective, this has been super effective, and it also ties in some of the real world events that ONC's pushing with real world testing, as well as collaboration with other EHRs, which is what we've been trying to do for a very long time, as well as other users of the documents. So, and we have newcomers. The only one suggestion I have is let's introduce newbies to each meeting so that we can get to know them better and understand what their goals are. And I'll put that in my survey, but yay, everybody's doing a great job. I'm just gonna say thanks, Lisa and John and everyone that's worked to make this a little bit different experience.
Thanks, Rochelle. And newbies, we'd love to hear from you. What could we do to make these introductions feel comfortable, more effective? As a community, we want to welcome and reach out and make this a comfortable place for folks who are new. For newbies, what could we do to respond to, like Rochelle's example? If we'd put you on the hot seat and asked you to introduce yourself or something, would that have been a comfortable thing, or can you think of other ways that we could encourage participation from newbies?
I'm a newbie. My name is Matt Davis again from DHIT. Pretty much a newbie for this first year. I've been in healthcare since 2012 after graduating college. And this past 12 months has really been the first time I've even got into anything of this nature. I don't feel like there's anything extra that can be done at the moment, because I feel like every topic has made room for me to wiggle my way around. It's not like I mention something and then I get completely shut out or shut down. I think it's important that everybody's voice is heard if they have questions. And I think each IAT I've been at, I think only 2 I've been at, that's been allowed. You know, there's room for that. There's room for people to hear each other out, and then also help people who may not know the obvious stuff. You know, a lot of this is stuff you learn over time. And if you are just being introduced to it within the last 3 months to 12 months, people are here to help you and say, hey, look, this is where I got what I needed from, or this is where you can go to start, and then you can go from there. So I feel very welcome here. And I really do enjoy it. It's an all-day process, but it's highly enjoyable.
Awesome. Well, if we had a gold star or something we could turn out, Matt, that's the best endorsement I've heard from a newbie. We're into stars around here. You'd get a gold star for sure.
Gold star.
And welcome.
And my last thing, because I did say that if you don't know the theme song to your favorite candy bar, you don't really belong on that candy bar. Mine is Kit Kat. Give me a break. Give me a break. Bring me up a piece of that Kit Kat.
Awesome.
Awesome.
I mean, just to add on to Rachel's point is, you know, if we were in person, we would have introduced everybody. I may have missed that, but I think that's kind of what she was getting.
Yeah, no, that's a good point.
Yeah.
And Matt, like Rochelle said, you know, you've made it in the community when you either get picked on by me or pick on me, one or the other. So.
Good to know.
This is Sue Ann from. It would be nice maybe if I could submit some of my questions ahead of time, because there's a little bit of fear that I'm going to either sound stupid or that this isn't the right forum to ask the question. So maybe, you know, like if I could submit them ahead of time, then you guys could filter through and go, well, this one, you know, we don't need to address that on this call, or, you know, that would be good.
I think that's a great idea.
Everything was
Would
great.
you be would you be comfortable if we made a spot on Zulip that says we're getting close to the next IAT? This would be we've started this thread to see what questions people are coming with or wondering about. Would you feel comfortable popping a few questions into a Zulip chat ahead of the meeting like that?
Sure.
I'm not sure how you think you're going to sound stupid. They let me do a whole presentation.
Yeah. I was going to say I asked all the stupid questions already, so you're good to go.
Okay, we'll count on that. We'll have a Zulip chat that will have you in mind and anybody else who would feel like that would be a comfortable place to put some questions up ahead. I think that's a great suggestion. Thank you.
And email is fine too. At least you're welcome to use my email, because I know within certain organizations it's almost impossible to get to Zulip, right?
Right. Well, that, and you may not be able to post, but if you're sending a direct email to somebody, it might, I mean, not that you can't access it, but it may be something that you just don't want your company name associated with because you're just still learning. And so a private email would be okay as well. So I think that's important, you know.
Right. That would be really nice too. I mean, I know, I go on the Zulip site a lot and read, just to learn and try to keep up with stuff. But to actually have contacts that I could reach out to, not necessarily from HL7C, because I realize you guys are, very busy and you've provided ways for us to contact you. But, other companies, competitors, at Cerner, like to be able to reach out, like to kind of co-workers or people that are in the to kind of.
Do you feel like you got our emails? Like, because that's something else that we could send. Dave has the master list of everybody who's attended, and we could definitely send out. Linda and I are serving as the co-chairs for the CDA management group. We'll make sure you have our emails, and Jean and Joginder will be facilitating the IATs going forward, so we can make sure that you have their emails, and that would be 4 of us. You could pick and choose.
That's awesome. I just want to make sure that I'm following like the rules and that I'm not reaching out to you guys when I should actually be posting it on Zulip, or if there's another way to submit stuff through the Confluence page. I don't want to be a pest.
Zulip the right way, and I would strongly encourage you to join those Thursday example task force.
Yes, that's
what a lot of those questions. I might get answered. You're joining and you had a question and it somehow gets answered by something somebody else is doing. It's powerful. Go ahead, Emma. Sorry.
Yeah, no, I was going to suggest that. That's how I've got acclimated, is joining those calls. And you typically will find the answer to your questions as part of the conversations, or you can just ask your questions there. People are really happy.
Or you can bring an example of something you think you want to do, and people will give you feedback on, that, or point you somewhere else to look for how it can be done. And more often than not, the questions that are asked there have not been asked before, and there are not examples for.
Or you get assigned something which forces you to learn.
That's right. One thing about HL7 is if you raise a problem, you will be assigned to help others fix it, right?
Very proactive group, for sure.
Great.
Wanda, were you trying to say something? I saw your square light up too.
Yes, I was just trying to say that by me, I'm from ONC, but by me not having specific like examples or from being from a clinical setting, I don't have specific examples to show, but I like to get on these calls just so I can learn how C-CDA works within the hospital systems and other systems that it's being used in. So that's just why I like to be on these calls. This is my second time.
Do you think also that I heard people recommend the example task force, and I know there's a lot of there are folks that attend example task force and do not attend the structured documents weekly meeting. I personally think that's a very good learning space as well. Certainly how I learned many years ago. So and you know, I think that, and plus you can kind of, that's one good way to really sort of start to learn the HL7 processes. And, you know, when you see CDAs in the wild flying around, there's a huge difference in them between those that have vendor reps that attend structured documents and the example task force versus those that don't.
Hey, and Gabe, that's a really important thing to remind me of how this works again, but there's something with you have to sign up for the listserv, right? In order to be able to see the conference information? Or what's the process so that they can actually see if anyone wants to join those? Because I know if you go and you have to have a login, or do you have to be signed up?
I think anyone can. I mean,
Yeah.
John, maybe correct me. Anyone can. What you theoretically won't have access. You can sign up and have a sign on, but if you don't have a member ID, then you wouldn't be able to access certain standards, certain non-fire standards if you aren't a member.
I was struggling the other day, though. I think maybe it's that you have to just log in. So you have to create a login and you have to be logged in to see the details of the call. Right. There's some weird requirement, right?
Once you've got a login and you don't need to be a member to get a login, then yeah.
But you have to create a login.
Yes.
Yes, you have to create a
and there's no cost.
You have to create a hl7.org login because that website manages your listservs.
And we like to be inclusive, and then maybe someday, if you're not a member, you'll become a member, right, Dave?
Exactly.
See the benefits of all of the people on calls like this that are willing to help.
The important thing too is the names here. This is my second time only, but everybody is pretty consistent. If you do have new people, you definitely have veterans, and it's comforting to be around you guys because I feel like you're so knowledgeable.
He's going for a second gold star.
Yeah.
Specifically.
Okay, guys, he's always like that.
You know, when they start citing directly from the rim, something's not quite right with people.
I tell you what, he's always like that. So he's not putting on for y'all.
I'm not putting on a promise. Emily, especially you, because I feel like you're such a prominent voice. So yeah. Definitely.
I'm the one always asking questions like, why are you whining and complaining about workflow?
You know, you're really, I was going to say, Matt, you're really perceptive because she's the hardest worker. Well, Lisa and she probably compete at the top for all the time they put into this. So thank you guys. It's appreciated.
All right, with that, I think we'll close this down. Thank you guys. I think we can claim another successful IAT. Again, any of the feedback that we've been talking about, please do add it to the survey. That way we've got it documented. We've heard what you're saying. We'll try and make things nicer for newcomers in the next IAT, but please write it in the survey. And we'll see you guys all on calls and at the next IAT if we don't see you sooner. Thanks you, everybody.
Thank you.
Yep.
Thank you, Jean.
Thanks, everybody.
Bye-bye.